Welcome to my YouTube channel. Today we're going to talk about management of VAT diabetes mellitus in pregnancy. So this is kind of management of pre-existing diabetes mellitus in pregnancy. Kindly make sure you subscribe. It will cost you absolutely nothing. So let's dig in. Management of pre-existing diabetes mellitus, as I mentioned before, in pregnancy. So we have goals of management, and the first goal of management is maintaining your glycemia. So in terms of maintaining your glycemia, we have goals of target that we have to achieve during pregnancy. That include fasting blood glucose of less than 95, 2 hours postprandial less than 120, 1 hours postprandial less than 140, and an HB1C of less than 0.6. So when you convert this into millimoles per liter, this will be less than 5, this will be less than 6, and this will be less than 7.8, and this will be this is 0.6. So how are you going to achieve your glycemic? You're going to achieve your glycemic in terms of diet and exercise, and also therapy, that is mostly insulin, in addition to oral glycemic agents. So another goal of treatment is to minimize fetal effects, as you already know, because if you are reading management or you are listening to the video of management of pre-existing diabetes mellitus, you already know the pathophysiology and its complication. And one of its complication is diabetes enteropathy, where we have anomalies caused by the diabetes because it affects the organogenesis. So in addition to that, you prevent associated pregnancy complications such as preeclampsia, among other factors, prevent DKA and long-term complication including childhood obesity, diabetes, and cardiovascular disease. So in terms of conception, we're going to begin our management in a very careful and very organized manner. So we begin with preconception care, where patients should be offered contraception to prevent unplanned pregnancy and to optimize glycemic control at least 3 months before conception. And this includes counseling the patients on the importance of good blood glucose control before pregnancy and during pregnancy to reduce maternal, fetal, and neonatal complication. I have a good video talking about pre-existing diabetes mellitus in pregnancy, which contains all these complications. So you can go and read and watch the video. In addition to that, you optimize the weight of this patient before pregnancy, and you advise this patient that the risk of getting diabetic child is 3 to 7% if one pregnancy is diabetic, and up to 40% if both pregnancies are diabetics. So, as you already mentioned before, our goals or our targets to optimize blood glucose control are as following: HB1C of 6%, 6% to 6.8, 6.5%, fasting blood glucose of less than 3.5, 1 hour plus postprandial is less than 7.8, and 2 hours postprandial is less than 6.7. So in addition to that, you advise the patient to stop teratogenic medication because diabetes is a disease that concurrently occurs with hypertension. They might be taking HACE inhibitors, ARB, statins, among other drugs. So you advise them to stop the drugs and you exchange the drugs in other drugs that are actually not teratogenic. In addition to that, adequate folate supplementation. You advise the patient to stop smoking, and you ensure good blood pressure control of less than 130 to 80 millimeters of mercury. So in addition to that, you assess for complications, the vascular complications, neuropathy, retinopathy, thyroid dysfunction. Does this patient has UTI? Because already UTI is diabetes is a risk factor of UTI, autonomic nephropathy, cardiac dysfunction, and actually manage these conditions or refer accordingly. Kindly highlight that this patient is a high risk patient and you will require them to have regular hospital visit, and that will include first trimester they can have monthly visits, second trimester they can have 2 to 4 weekly, and that trimester they can have twice weekly. In addition to that, you advise them to regular home blood glucose monitoring and adjust the insulin doses depending on the blood glucose level, because if they are monitoring the glucose level, then you're going to see, are we achieving our normal targets? If you're not achieving our normal target, then you have to adjust the dose of insulin or the dose of actually the hypoglycemic agents. In addition to that, normal ANC screening and need to repeat screening for complications in second and third trimester. You do urinalysis, UEC, FBC, and ultrasound. So in addition to that, an appropriate diet and appropriate exercise during pregnancy as previously mentioned. So detections of malformation, as we said before, that this pregnancy is more predisposed to having diabetic enteropathy compared to gestational diabetes. So how do you detect this malformation? By having a first trimester HB1C. A high HB1C indicates a poor control of glycemic, so that is an indication that you will have a higher risk of having malformation. First trimester screen, you do alpha fetoprotein at 16 weeks. In addition to that, you can also do the quad screening test at 16 weeks. The quad screening test contains alpha fetoprotein, beta HCG. You can also have unconjugated estradiol and inhibin A. So in addition to that, you'd also do an ultrasound at 13 to 14 weeks to detect obvious anomalies, which could include maybe an encephaly and comprehensive anatomy survey done at 18 to 20 weeks, in addition to fetal echocardiogram done at 20 weeks if actually necessary. Then antenatal follow-up in any diabetic patients on medication, you will need a growth scan every 4 weeks after 20 weeks. This is because these patients are predisposed to having stillbirth, and these patients are predisposed to having intrauterine growth restriction, among other complications. So actually, you need a growth scan every 4 weeks after 20 weeks to monitor that. Antenatal testing, that is non-stress test, you need to start them at 32 weeks unless there's an history or unless there's intrauterine growth restriction dictated on ultrasound, then you need to start this earlier. And then just this is a repetition, as we said, our targets, HB1C, by now you should have already known them. HB1C should be 6 to 6.5, fasting blood glucose should be less than 5.3, 1 hour postponed should be less than 7.8, 2 hours postponed should be less than 6.7. And then you advise the patient on nutritional counseling and should be offered during pregnancy. So glycemic control. So let me just summarize this for you. So in diabetes, pre-existing diabetes, the major classification of diabetes mellitus is two: type 1 and type 2. Type 1 is where you don't have insulin. Type 2 is where you have insulin resistance. I hope you are clear. So how we treat type 1, we give insulin. How we treat type 2, you give medications such as metformin, that is the oral hypoglycemic medication, which help reduce the insulin resistance. Now, in pregnancy, already we have insulin antagonists in the pathophysiology of pregnancy. Already we have insulin antagonism. So most of these patients in type 2 diabetes, if we don't get a good control of blood glucose to achieve our targets, then we initiate insulin therapy. So that is what majorly this slide say. So metformin and glibeclamide can be used safely in pregnancy as long as sugars are controlled to target. So if the sugars remain high, then you intensify the therapy to switching the treatment to insulin therapy. So in patients with type 1 diabetes mellitus who have deficiency of insulin must obviously remain on insulin therapy, and it must be titrated to the target. So due to the changes in pregnancy and increased weight, and most females will be better controlled on insulin management. So one of the complications that insulin diabetes predisposes a patient to have during pregnancy is preeclampsia. So you usually start this patient on low dose aspirin, that is 75 mg or D, should be given in patients to prevent for prophylaxis of preeclampsia from 12 weeks to term. And then first trimester nausea and vomiting may cause hyper and hypoglycemia that will warrant changing the therapy and dosing. An ultrasound, which as already have said before, specifically a fetal anomaly ultrasound, can be done at 18 to 24 weeks to rule out congenital anomaly. And then monthly scans should be done from 28 weeks till term to assess fetal growth and amniotic fluid index. This amniotic fluid index is used to detect polyhydramnios, which is diabetes is a risk factor of causing polyhydramnios. So an amniotic fluid index of greater than 25 is an indication of poor glycemic control. So in terms of delivery, we aim delivery at 38 weeks, and giving steroid would assist the maturity of the lungs. So delivery can be spontaneous, induced, elective, emergency, obviously depending on this individual patient. So we don't have to say that all patients go for delivery. No, you have to consider this patient. What complications do they have already? Pregnancy complication. Do they have any indications for cesarean section? Can they do spontaneous delivery? How much is the weight of this baby? Can they go for the spontaneous delivery? And the delivery should be in hospital. So in terms of induction of labor, diabetic women controlled on insulin are usually considered for induction of labor after 38 completed weeks. However, women with vascular complications such as preeclampsia, intrauterine growth restriction are often require induction after 37 weeks. So just to say, women whom we have achieved control through insulin, then you can contact delivery at 38 weeks. However, the rest of the women who have complication, then you have to individualize the treatment according to that patient. Glycemic control during labor. So glycemic control during labor and birth is utmost of importance to avoid adverse neonatal complication. So it ensures your target for blood glucose should be maintained between 4 to 7. And then we have a solution called GKI, so which is glucose, potassium, and insulin infusion, which one is usually is given during labor, especially in cesarean delivery. So this infusion contains 10% of dextrose 500 ml, 10 millimoles of potassium chloride, and regular insulin 10 to 14 units, obviously depending on the blood glucose. And it is usually given to rent 5 hourly. And it should be prescribed at the onset of labor. And as I said before, this infusion are usually useful for glycemic control during cesarean section. So for following after delivery has occurred and you've already removed the placenta, then you have the dose of insulin. So meaning now you'll have a 10% dextrose 500 ml, 10 millimoles of potassium chloride, and regular insulin now will be 5 to 7 units. Usually have to run for 5 hourly to prevent hypoglycemia of the mother. Once the mother now is able to feed, then you give the mother pregnancy doses of insulin or oral hypoglycemic agents. So the care of the neonate, obviously this neonate is already conditioned to having conditions of high glucose levels, and now they are already delivered and maybe they don't have those conditions. So you must do a blood glucose after the birth of the neonate. If the neonate is stable and there's no hypoglycemia, then you advise the mother to initiate a breastfeeding. It is advisable to admit all neonates for 6 to 24 hours with if they have hypoglycemia and they're symptomatic. You admit them into the neonatal newborn unit. And then you monitor their blood glucose 3 hourly for 24 to 48 hours. And your target or you aim at maintaining the blood glucose for 4 to 7 millimoles per liter. So if you have a case where you have hypoglycemia that is less than 2.8 millimoles per liter, then you give 10% bolus dextrose 2 ml per kg and advise the mother to feed. In addition to that, you also monitor any complication and encourage breastfeeding. So a neonate born to a mother who had poor control, especially in the first trimester, should this statement even there's no need of explaining because you already have said in the first trimester is where you normally have organogenesis. So in this time we already have diabetes, which will predispose this infant to having anomalies. So you normally screen them for congenital anomalies. So postnatal care, you ensure breastfeeding has been established. One of the complications of diabetes in during postpartum period is number 1, puerperal infection. So you increase the surveillance for puerperal infection, especially in the surgical incision and wounds. And you normally give prophylactic antibiotics in this case. So patients should go back to pregnancy doses of insulin or oral hypoglycemic agents. Obviously, this is after performing a random blood sugar levels after 24 hours for you to adjust these doses. So in addition to that, our target to maintain blood glucose control between 5 to 9 millimoles per liter. You encourage this patient to take contraception at 6 weeks because we said pregnancies for these ladies have to be planned. So to avoid unplanned pregnancies, then you advise contraception at 6 weeks. So any patient with vascular complications should avoid estrogen-containing contraception. So why? Why are we avoiding? Because one, during postpartum care is when we have an increased risk for thromboembolism events. And number 1, already that's a risk factor postpartum. Number 2, if you give estrogen-containing medications, then actually you're kind of worsening the situation. So we advise to avoid estrogen-containing contraception in patients, especially with vascular complications. Thank you.